up to webinar episode 35, improved aligner patient satisfaction with minimal refinements. There's no doubt today's most integral topic is aligners, and our fastest growing product here at Race Dental is our Race Aligner product. So who better to ask and invite to come on board? There's a few late numbers pouring in now, so I'll just wait a little longer. We do have the numbers absolutely soaring here. Before I introduce our guest speaker, we'll just give a few more people some time to come on. Whilst we're waiting, just want to let everyone know ADX is coming up. How exciting, the Australian Dental Exhibition. If anyone's interested to come and see the future of dentures, streamlined workflows for accurate digital results, a lecture that I'm giving, come along and join the lecture at ADX. It's on 2 days, so check out your ADX guide and find when those 2 lectures are and come on down to learn how to turn 5 or 6 visits in delivering a denture into 2 visits with a digital workflow. Digital dentistry has really shaped the way forward on our streamlining the way we deliver dentures. So come on down and have a look at what we do and find out how to turn 6 visits into 2 to manufacture both partial and full dentures for you or patients. Okay, our attendees seem to be alive now. Their numbers are slowing. Most people have come on board. So welcome everyone who hasn't joined us already. We do have registrants I can see here from Malaysia, Australia, Singapore, New Zealand, and Fiji. Welcome to everyone from Fiji. So as I mentioned today, improve aligner patient satisfaction with minimal refinements using aligners. Who better than to ask someone who has done in excess of 2,500 aligner cases over his years. Owned a successful cosmetic practice in North Sydney, someone who knows the industry inside and out and who is very capable and knowledgeable in the aligner space. Welcome, Dr. Cronin. Thank you for joining us today.
Thanks very much, Matt. Thanks for having me.
Pleasure. I'm looking forward to, we've got a number of questions in and around the aligner space, and so many people and attendees are still flooding in right now, but the importance of case selection, managing patient expectations, planning protocols, the large role that patient compliance takes or makes in the successful delivery of aligning teeth, troubleshooting mid-treatment, patient retention, and all that during part of active treatment. So, Luke, without further ado, mate, over to you.
Thanks very much. Just let me share my screen just in a moment. All right. So yes, there's no doubt that aligner treatment is growing very rapidly currently. And one of the big issues that dentists face is that we often end up in these very circular refinement loops. And there is a way to prevent that. And what we're going to do today is try and simplify that process to get more predictable results. All right, so as Matt said, we're going to go through the importance of case selection. We're going to go through essential treatment planning protocols. So we're going to talk about overcorrections in that section. We're going to talk about what sort of attachments you need and IPR. We're going to talk about dental monitoring. And then finally, are we going to see if your patients are compliant, how to troubleshoot mid-treatment, and is retention part of active treatment, which is a good question. So the goal in any aligner treatment is to complete the treatment the first time. So and that by the first time, I mean in the first series of aligners. And I'll explain there's some exceptions to that, but that should be our goal for most simple treatments. So what outcome are you expecting? Is that outcome aligned with what the, excuse the pun, sorry, with what the patient's expecting? How long is the expected treatment? So most treatments that I do these days are between 4 and 7 months. So we're really looking to shorten down the length of time that we're having people in aligners, which has a direct impact on the compliance rates as well. You need to look for more complex movements. So when you've got multiplanar movements, for example, rotation and extrusion, that's when you're going to start to have off tracks, and that's when you need to start looking for refinements. But for most simple treatments, you should be trying to finish it in the first round. At Race, we offer a clinical opinion. So if you're not sure, if you want to know how long the treatment's going to take, whether you think it's going to need a refinement, you can ask us prior to commencing the treatment. And if the case is too complicated, then you can either engage a mentoring service, you can ask us for help. But basically what you want to be doing is growing your orthodontic knowledge slowly and always have predictable outcomes, because that is what keeps your patients happy. So we're just going to go through an example of a simple case here. So in this case, we're doing simple expansion, small rotations, and some intrusions on the lower anteriors. This is pretty typical of a lot of cases, these combination of movements. So we're initially creating the space here through expansion. It's not too much proclination in this case, and rotation. I'll have a look at the lowers as well. You can see we're creating that space with expansion, and that's creating space for that tooth to move forward back into alignment. We look at a more advanced case now. Sorry, we'll go back. With me. So we're starting to introduce some multiplanar movements. So if you look at that upper lateral, it's both rotating and extruding. We're going to talk about attachments soon as well, and it's very difficult to do both of those movements at once. So again, like most aligner treatments, we're creating space through expansion, proclination, and then if necessary, IPR. And we'll talk about when IPR is necessary. Caveat on that, IPR is necessary in most cases. We'll explain why. And we're going to look at a couple more advanced cases. So this case here, we've got significant amounts of intrusion. We've also got palatal root torque on those anteriors. You can't see it from that angle. But again, these multiplanar movements are far more complicated and are likely to lead to off tracks. So you can see as they're retracting, they're also talking at the same time. Aren't they, Matt? You see them talking? And one more complex case before we get into the nitty-gritty. Again, you'll see on these laterals that we've got extrusion and we've got rotation happening simultaneously. So cases where you've got that multiplanar movement are far more complex. So what are the elements that you need to consider when you're planning an aligner treatment? Overcorrections. So this is a big problem. So what we do with aligner treatments, we show our patients what the outcome's going to be. If our aligner setup is correct with overcorrections, then the teeth aren't going to look straight. So it's a little bit confusing for the patient to be able to understand why their plan doesn't look correct to get the correct outcome. So this is something that you really need to overcome, because without overcorrections, you're guaranteeing yourself a refinement. Attachment selections, we'll go through that briefly in a moment. IPR, when and where. And predictably of movements, as I alluded to earlier, multiplanar movements are more unpredictable than single plane movements. So here's just a little bit of a snippet. At Brace, we've got the protocols around how much overcorrection. So I've just given a snippet of, the kind of things that we will add to the treatment plans for you. And you can either elect to have us add these to the treatment plans or not. If they're not added, though, you will be requiring a refinement. And unfortunately, in the refinement too, if you don't have some degree of overcorrection, it's unlikely to align completely anyway. So on this, we're going to have a look at an example of a rotation overcorrection. So here we're looking at the 2-1. It's rotating mesially, and you can see at the end of treatment, we've rotated it slightly overcorrected mesially. And the reason for the overcorrection is that the aligners flex and the circular fibers are trying to relapse that tooth, but that aligner flex means that that tooth isn't into the exact position as it is on the actual viewer. So without those overcorrections, the aligner is always going to flex and you'll end up in that refinement situation. So what attachments are required for the following movements? And you'll see once we go through this, why, when there's multiplanar movements, that they don't express correctly. So there's rotation attachments, there's extrusion attachments, there's intrusion attachments, root torque, root tip, translation. So rotation attachments, you need to put the force behind the point and move it forward. And the other thing is, most rotations are not actually pure rotations. They've got some translation. So this movement here is likely to translate forward, and it will require some mesial IPR as well. Extrusion attachments, they need to be beveled towards the gingiva. And the reasoning behind this is, as the aligner changes, it still's got this broad area that you can push on the attachment, so it doesn't off track so quickly. If we had that upside down, then it off tracks very quickly because it jumps off that ledge and there's no more force. Intrusion attachments, and this one we see a lot. So the attachments for intrusions are not actually on the teeth that are intruding, because the plastic is actually pushing on the teeth. What the intrusion attachments are doing is preventing that plastic from lifting up posteriorly so that it can maintain that force on the anterior teeth. We'll talk about IPR protocols. So we have a protocol where we use up to a maximum of 0.5 mils IPR. That's pretty typical as an industry standard. But what we try and do is we try and keep the plans to be very predictable. So we're looking for midline correction. We only spread evenly over the anterior 3 to 3 and only up to a maximum of 0.3. We do this to prevent the teeth from starting to tip, and also beyond that, it's very difficult to get a result. The IPR to improve the overjet. We spread this evenly between the upper 3 to 3 up to a maximum of 0.3 mil, unless we're trying to correct the midline at the same time. Class 1, IPR, typically you'll have a Bolton discrepancy. So we spread the lower IPR 3 to 3 around the lower 3 to 3 up to a maximum of 0.5, and we do that only to correct the Boltons. For class 2, if you're not going to be electing for using elastics or molar distalization, then you can disguise that through IPR in the upper 4s and 5s to improve the canine class. And the same as the reverse for class 3. We also use IPR for black triangle reduction. So the whole idea behind this is we're just trying to keep things simple. So teeth that require significant movement in 2 planes, that's i.e. that's not just a rotation, that's a rotation and an extrusion, for example, which you saw some in the earlier examples. You typically see that on the upper laterals and lower canines, and proclination and intrusion, which is typically on the upper central incisors. So the intrusion, in these cases, if you're trying to do those movements simultaneously, the intrusion or the extrusion movement is the least expressed. So you've got an option. You can stage the movements. So you could do the rotation and the extrusion separately, or you complete the rest of the movement in a refinement. So there's some things you need to consider. Sorry, excuse me. Let's get that video playing for you. So you can see that lower canine there. We are rotating and uprighting at the same time. You will get some rotation on that tooth, but without proper planning, you're going to end up with a significant off track, as you can see in that picture to the right. This is something we see commonly. And this is why, ideally, what we want to be doing when we're doing our treatment planning is to follow our treatment protocols, because if they get modified too much, then we start to notice, and we're going to go through DM in a moment, the protocols get modified too much to the point where unpredictability, then we start seeing these sort of outcomes coming from the patients. So with race aligners, dental monitoring is included in the price. And the reason why we do that is because we want the best outcomes for the patients. It also gives us a significant data mine for us to be able to refine and improve our protocols and be able to provide even better customer service for the dentists. So what is dental monitoring? Dental monitoring essentially is an AI product. The patient takes a scan once a week. Following that scan, what we are looking for essentially is whether the aligner is seating properly. It does offer a whole raft of other alerts such as hygiene and recession, but the main ones that we use in our planning is that the aligner unseats and working out why they're getting an aligner unseat. So after 7 days, they'll be asked for a scan. If the aligner is fitting, it will say that you can go on to the next, or tell the patient they can go on to the next scan. If it says no, then it will ask them again in 3 days.
Transform your patient's treatment journey with dental monitoring. This is Kate. Kate made an appointment with your practice to align her teeth. After a comprehensive clinical exam confirms your diagnosis, you present a treatment plan and outline the costs. Kate is now ready to go. At the start of any treatment, whether aligners or braces, present the ScanBox Pro to patients and ask them to download the dental monitoring app. With this app, Kate will be able to follow the evolution of her smile wherever she is and stay in touch with you and your staff. How does it work? It's very easy. At the intervals you set, Kate scans her smile using her smartphone and the ScanBox Pro. The photos are processed and analysed by our artificial intelligence platform, which automatically generates notifications based on the protocols that you will have developed specifically for Kate. If all goes well, Kate does not need to come in as often, and you can focus on in-office clinical care on the patients who need it most. That's not all. We know that you want to stay in touch with Kate for proper follow-up with her treatment. Our app makes it very easy to send personalised messages, set up appointments, and send instructions or annotated photos at any time. It's clear. Dental monitoring is a win-win for doctors and patients. What are you waiting for?
So, are your patients compliant? Without monitoring, you don't know, is the short answer. And the biggest problem with clear aligner therapy due to their removable nature is that your patients are often non-compliant. And if they're non-compliant, then the treatment outcome just won't be achieved. You just imagine it's like a gym membership, you can pay for it. You don't turn up, then nothing's going to change. So what are your compliance protocols? You need to be able to prove compliance, because every patient will tell you that they are wearing them regardless of whether they are not. And in order to be able to rule out poor planning over poor compliance, you need to have some kind of monitoring protocol. We use weekly dental monitoring scans because any other way of bringing them into the clinic is very inefficient. And we were talking before about those extrusion attachments, and often when a lateral is extruding, it will start to off track due to binding with an interference on the adjacent teeth. And if that isn't picked up early, that the aligner will jump off that attachment and start to create the opposite force. So without spotting that in the week or two after it starts and performing the appropriate IPR, you're going to end up in a refinement very quickly. And the other thing is having aligner change on the actual movements rather than arbitrary timeframes makes sense, because they're looking for each aligner to complete what it's supposed to do prior to moving on to the next one. And how do you identify poor compliance versus a collision or poor planning? It's very difficult to do without any type of monitoring system, because otherwise, if you arbitrarily bring them in every 6 weeks and you're having a look, it's not fitting. You can check IPR, but how good was their compliance in that period? And how can you start to audit what is the problem? So here you go. This one's pretty obvious. This is a very non-compliant patient. They never had a green light in their whole treatment. They had a scan at aligner 2 and gave up, and then obviously changed to aligner 7 in the following months. And then they've got to February and they've got 1 green light, which is very surprising at number 11. And then they're on number 12. Now, the biggest problem with non-compliance is that a lot of the expansion that's programmed doesn't express. So you end up with significant crowding issues that are very difficult to unravel mid-treatment. We'll have a look at a compliant patient, for example, here, and you can see the before and after outcomes are great. You can see that they've got all the way to aligner 11 before they had a no-go. So the further you get along and the more the treatment plan's extrapolated, the more likely you are to see no-goes. And at some of these no-goes further down the track, IPR would have been required. And we'll talk about that in a moment. But you can see this patient's extremely compliant. If they're compliant with the 7-day scans, they're likely to be compliant with their aligner wear. Because if they don't bother scanning, they're not bothering wearing the aligners at all. This is also a compliant patient. Why do you think there's all these no-goes at the beginning? Any idea, Matt?
Not too sure. Maybe there's a seating issue. Don't know.
So what they've done is they've changed their aligner and then done their scan for the first 3. So rather than scanning after the end of the first week and then being told whether to change their aligner, their onboarding wasn't correct and they've changed their aligner before they did their scan. So you can see they fixed that up later down the track and did their scan before they changed their aligner. So mid-treatment troubleshooting. Basically, we've already got our plan. All of our plastic is manufactured from the start of treatment. We've got our overcorrections in now. We've got our planned IPR. Why do we need to do mid-treatment IPR? A lack of expansion. So all of these processes are biological. If there is not enough expansion to unravel the crowding, then you're going to have some unforeseen collisions and rotations and extrusions. So that's the importance of monitoring so that you know when to intercept and in a very timely manner. So with these interceptions, then you will notice once you've done the interception, they go back to do their next scan, the green lights will start again. We can assist you specifically on what to do and what to intercept as well. So here's a couple of reasons why. Lack of expansion is very common, particularly in poor compliance. Unforeseen collisions. So we were talking earlier about the extrusion of laterals because the tooth shape is predicted based on the scan. So often it will bind, and that's the reason why you'll need IPR mesial and distal to a upper lateral, for example. Inadequate planned IPR. So with the dental monitoring, you don't need to do exactly what the amount of planned IPR is, because as the treatment goes, you can always do more because you're going to be alerted to when it runs out of space. And when you're doing IPR that is planned, it needs to be at the final contact point. So not along the whole edge of the tooth, at the contact point where it's finally going to rest. So what we do is typically wait for 2 no-goes. So they've scanned at 7 days, says no. Scan 3 days later, so 10 days says no. And then we're going to start to have a look and see what we might need to do. So what we do is we compare the initial plan and the IPR summary with the dental notifications and the alerts. We assess what movement's trying to be expressed and the tooth that isn't tracking. So we're having a look at this case here. This case has only got planned IPR between the upper right canine and upper right first premolar. This is the case that I shared with you earlier that has the no-go starting later in treatment. So what we then do is we have a look at their initial plan. We can see here we've got a slight unseat present on the 4-1 on the left-hand side of the screen. So if we're looking at this plan on the right, that 4-1 is likely going to be impinged by the rotation of the 3-1. So in this instance, we would recommend some IPR between the front 2 central incisors. And once that IPR was performed, then the patient went back on track again. Here's another example. We've only got some minimal IPR down the lower. We've got the patient was reasonably compliant. And we're starting to see some binding happening. And we'll look at the plan. So there's a big rotation on that upper lateral mesially. So in that situation, it's likely to bind on the mesial as it's rotating. And we can start to see, what have we got here? Noticeable unseat on the 2-1. So the 2-1 is getting a little bit stuck on the 2-2 as a result of that rotation. So what we did, we requested the doctor do a little bit of IPR mesial of the 2-2. And then we did the scan. What's this scan? This is a couple of weeks later. And you can see that the aligner's seating again. So these are the things that when you're intercepted early, you can keep the patient back on track and prevent those endless refinement circles. This is the typical example that you will see with laterals extruding. So we've got the correct attachment. We've got the beveled, essentially like a lemon pip theory, squeezing the tooth out. And often they bind mesial and distal. There's some planned IPR to the distal. You're starting to see on the left here, see it says in the observations from dental monitoring, slight unseat 2-2. We're expecting that almost with that sort of extrusion, sorry. So we advise the dentist to check this, make sure there's no binding mesial distal to 2-2. And then the next scans, it's back on track again. So you can see the importance of being able to monitor it closely to ensure that these things stay on track. And I guess the last one we're going to talk about, Matt, is the retention part of active treatment. So I've got all these overcorrections that we put in our plastics, and we're looking towards the end. So the active aligners are from a material with a high modulus of elasticity, such as EnduraFlex, which is the material that race aligners are made out of. The retainers are, or the passive aligners, are manufactured from a more rigid material, such as Essex, which was the original aligner plastic that was used way back at the beginning. We've realized that the higher modulus of elasticity helps with movements better, but doesn't help with retention as well. So if we think about it, we've got this harder plastic that can be used to finalize the movements. It has less flex, and we're looking to get the teeth in the ideal position in the retainer. So there's no reason, well, I'll start at the top here. Retainers should be worn 3 months full time prior to the placement of fixed retention, in my opinion. I always advise that the patients, so say we've got a 4 to 7 month treatment plan, I will then add on 3 months. So you're either going to be 7 to 10 months. That's your full-time wear. It increases the stability and allows the movements to finish. If you get to the end and the patient's fixating on the teeth that's slightly out of alignment, by putting them into the retainer and enabling that movement to complete, it will also stop the patient from staring at it as often as they do, because oftentimes it's not actually the position, it's the shape of the tooth that needs to be improved. I always do this for at least a month, even if I'm intending on doing a refinement. There's no reason why you can't perform IPR in the retention component, because if the teeth, particularly the lower anterior teeth, if the rotations aren't complete, you can perform some IPR to create a little bit more space to line up those teeth to prevent you going into a refinement. So I guess the crux of this, Matt, and the big things that you need to think about is all your treatment plans need to have overcorrections. You need to monitor during treatment so you know when the patient's starting to off track or they're being non-compliant. And then when you're seeing those off tracks, you really need to intercept quickly and early with a little bit of IPR in most circumstances to keep these treatments on track. And if you've got these complex multi-planar movements, you're definitely going to need refinement. So build that into the conversation you're having with the patients before you start.
Mate, thank you, Luke. Very comprehensive. There was a lot of people coming on board late there. I was watching the numbers still climbing after you started. I know you're a key opinion leader for 3Shape, Philips, Ultradent, Race, and Invisalign. So I know you're well positioned to answer the questions that have come flooding in. Not to mention the 2,500 plus aligner cases that you've done, most of which were done with Invisalign. So no doubt well positioned to answer these questions, Dr. Cronin. I'm going to jump straight into the deep end. Does the Scanbox Pro come with every case, or is it at an additional cost?
With race aligners, we include a scan box with every case, just because we see the value in keeping the patients on track.
I can imagine that is what enhances compliance when they know they're being monitored, especially the young patients today who are addicted to their phones and want to be doing something with the phone at all time. If they do have a way of scanning themselves, I guess that's adding to compliance and decreasing the chance of refinement. Would I be correct in saying that, Dr. Cronin?
That's right. So the compliance is key, and the fact that we can actually record the compliance, but also the monitoring is more to keep the treatments on track, because we're seeing these slight unseats that as a result of a collision, which otherwise we're just waiting till the patient comes back in to check the collisions by flossing or with IPR strips, or looking at the unseats that are present at the particular time. Whereas we can pick up these unseats far more quickly and intercept at exactly the right time, rather than waiting for their next appointment.
Fantastic. Is there a hands-on course run by Race Aligners?
We're about to launch one very shortly. So we're looking at a 2-day course where we're going to be doing hands-on for the initial steps of the course. As we're going to be going through all the orthodontic theory. We're going to go through scanning and photos. And then from there, we move on to attachments on and off, IPR. And then we look at the dental monitoring side of things, how that fits in. And then finally, following that, we look at retention protocols, both fixed and removable, and when's the right reason to use one or the other, or both.
Awesome. There's been a lot of questions around hands-on courses, so looking forward to being part of that. Dr. Cronin, can the final retainer be sent with the aligners at the start of the case?
To the patient?
I guess sent out with all the aligners, and if the patient's picking up the aligners from the clinician, learning how to use the Scanbox Pro, and then going off to be monitored, can the retainer be sent at the start of the case?
Typically, what I will do, I will issue the patients with all of the aligners, including the retainer, and the patient will then get alerts through dental monitoring, and they'll be advised prior to leaving as well that they're required to come in to have their attachments removed prior to having the retainer fitted. There's a couple of reasons for that. With the number of cases you're doing, it's very easy to lose a retainer that's sitting in a box in a dental surgery. And the other one, and I've only ever had it happen once, where the patients put the retainer in with the attachment still on. So I don't see any reason why the patients can't be in control of their own treatment, because that part of that, ownership of it and the scanning and all the things that go part of that treatment is essential that they have that ownership.
Makes a lot of sense. Dr. Cronin, can you bleach teeth using an aligner during treatment?
I believe you can, because when you're whitening teeth, you're whitening the dentine. So the enamel is translucent. So the whitening gel will permeate through the enamel into the dentine, and that will change the color during the treatment, regardless of whether there's an attachment there or not.
And there's no degradation to the Zenduraflex material currently being used in that aligner?
No.
Okay, and I've got someone here who may have come on late saying, as the clinician, how involved can I be with regards to the dental monitoring?
We have a monitoring team that monitors the aligners. If you want to get involved, we do offer that. We just got to make sure that we know who's controlling what, because there's a lot of communication that goes on when it comes to dental monitoring and patient management.
Fantastic, Dr. Cronin. Again, thank you for your time. Your wealth of knowledge in the amount of cases you've done here well positions you to be delivering this today. I'm going to throw you under the bus in one moment and ask you for one last opinion on why you think race aligners, you've chosen race aligners over and above the competition. But before I do so, I'm going to remind people that on Thursday, the 21st of March at 10:15, we have the ADX Future of Dentures, Streamlined Digital Workflows. And also Friday, the 22nd of March at ADX as well. 2 p.m. we have the same lecture. So come along and learn how to turn 6 visits of denture manufacture of 6 visits to deliver a denture into 2 visits. So there you go. We have it. But Luke, as I mentioned, one last hurrah. Why race aligners over the competition?
So our treatment protocols that we use include the overcorrections, which is market leading. If you're looking to do that with other systems, that you need to have your own protocols. You need to advise them exactly what movements you want. So that, and coupled with the monitoring of the monitoring, so the fact that we monitor the dental monitoring and alert you as to where and when IPR is done, I think it's just a more comprehensive solution for busy general dentists, because a lot of that, unless you're doing hundreds and hundreds of cases and you've got your protocols set out and your staff running everything like clockwork for you, so to the point almost where you're not doing anything, these sort of concierge type services make a massive difference to clear aligners in your business.
No brainer. Makes a lot of sense. Jump on board. We're looking forward to the 2-day course, Dr. Cronin. If anyone would like more information, please contact customer support at racedental.com.au. Alternatively, go to our website, racedental.com.au, and go to education. This webinar has been recorded and will be live under the education component. If you still want to know more, come along and see Luke Cronin. Dr. Luke Cronin will be lecturing at ADX as well. So come along and see his wealth of knowledge being poured out on the national stage. But again, thank you, Dr. Cronin, for your time. Thank you, everyone, for coming along to episode 35. We're looking forward to seeing you all next webinar series, episode 36. Thank you very much for your time. Thank you, Dr. Cronin. Good night, everyone.
Thank you.